Welcome, everyone. We're just letting the waiting room open, so we're going to wait just a few more seconds to let everyone connect. We're about a minute before our start time, so don't want to start early, so we'll start shortly. If you need anything before we get started, feel free to reach out to me in the chat. I'm Nan. I work with ACHE on the virtual programming, so if you have any questions or technical issues, feel free to send me a quick chat. All right, I'm going to go ahead and get us started. Again, I'm Nan, so if you do need anything, feel free to reach out in the chat. I work with ACHE on their virtual programming. We are very happy to have you with us this evening. I am welcoming you to ACHE Nevada chapters panel discussion on disruptive innovation in healthcare delivery. Before we start, just a couple of quick things for housekeeping. Your session is worth 1.5 hours of face-to-face credit education. Please be logged on for the entire 90 minutes to receive the full credit. Make sure your name matches the name you registered with. If for some reason your name doesn't match, feel free to reach out to me. I can change it, or you can go ahead and change it at this point. You will receive your credit in about 2 weeks following the end of the session. It will be within the acha.org website where your My Events is, and you'll see the course and you'll be able to find the certification there. The session is being recorded, and you can also go into the learning management system to watch this after approximately 48 hours where it will be posted. For noise control, you are muted. I have been told you can go ahead and put questions in the chat if you have any, so feel free to go ahead and use the chat if you have any questions you'd like to address. And that is everything I have at the moment, so I'm going to go ahead and get this started for y'all. I'm going to turn it over to Mitchell. There he is. Mitchell Fong is going to get us started by introducing our moderator, and we'll go from there. Thank you, everybody.
Thank you, Nan. Hello, everybody. I'm Mitchell Fong. I'm the Vice President at ACHE Nevada chapter this year. I'm really excited about today's panel. We've got a great group of speakers that are local as well as external from our state. So really excited to hear what they have to say. I'll kick it off by introducing Brian Rosenberg, who is actually the president of our Nevada HIMSS chapter and our panel moderator today. Brian is a managing director with KPMG and has over 20 years experience leading transformation projects for healthcare providers, such as implementations of ERP solutions and Epic. His projects have included roles in implementation strategy, software selections, change management, and project advisory services. He's designed shared service operations for many of the largest healthcare providers and has a Six Sigma Master Black Belt, is certified Kaizen facilitator, and change management professional, is the former CEO and founder of a leading ERP implementation firm. So thank you, Brian, for being our moderator today and demonstrating the partnership between our HIMSS and ACHE Nevada chapters. I'll turn it over to you.
Thanks, Mitchell. Appreciate it. And first, I do want to mention, thank you to ACHE for hosting this webinar. And this is part of a ongoing partnership between ACHE and HIMSS here in Nevada. For those of you who may not be familiar with HIMSS, it is the healthcare IT organization that is IT professionals in the industry. So we work with ACHE nationally and have established a variety of ways that we're working with ACHE locally here in Nevada. We have a really exciting and interesting topic today. We're going to be talking about disruption in the healthcare industry. And we have a group of panelists who I'll be introducing in a moment, who all bring experience across the industry, and each of them is involved in disruptive activities with the companies that they're a part of today. I think, when I look at this, I have had about 25-year career working in healthcare organizations and helping them to implement large scale change. And I think we all know that change in our industry is hard. And we're going to be talking a lot about that. And I will tell you from my time in meeting these panelists earlier, as well as my prior experience with several of them, that this panel is going to challenge you. And we're going to ask a lot of questions about the industry and talk a lot about what works and what doesn't work about disruption. And so I'd like you to approach this with an open mind, think a lot about how this applies to the organizations that you're a part of and the roles that you're a part of, and encourage you to ask questions, because I think that we have a good agenda that we're going to be covering today, but your input is important. We want to get your questions out. So as opposed to, I think a lot of these kinds of sessions ask you to hold your questions to the end, we're not going to do that. So if you have questions, feel free to put them in the chat box. We will organize them to some extent. We may take some of them at different stages based upon when we're going to be talking about different issues. We'll make sure to cover them all. And if we don't get to them during the session, we'll cover them at the end. But please go ahead and populate them as you think about. So, I think also looking at the panelists that we have are all involved in businesses that are attempting to disrupt the industry in new ways. They've all been involved in disruption in the past on one form or another, and they're involved in new disruption. So I think that, first I'd like to give you to understand better who the panelists are, some of their background and some of what they're doing. And then we'll start to talk about disruption and change in the industry. So Guillermo, go ahead and start with you.
Thanks, Brian. So I'm Guillermo Ramos. I'm a native Argentinian, but grew up in Spain and came to the US in '96. And I've been dedicated every year I've spent in this country to supply chain healthcare, focused mostly on technology. Started working at, with basic things like ERP software, those kind of things. Companies like Shared Medical, which now is part of Cerner, or CSC Consulting. But then later on, I started seeing some of the challenges that healthcare provider organizations were facing in the supply chain world. And so I joined what is now Vizient, and I was there for about 7 years, designing and developing and actually commercializing innovative price benchmarking analytics applications to help those providers. And then in 2014, I came to California, and that's where I started coming in contact with the startup universe and getting more and more interested in problems that were affecting like the entire industry, rather than just what I see as one side of it, which in my world is the providers is half of the industry and the suppliers are the other half, right, in the supply chain world. And so I decided to start looking into some of these bigger industry-wide issues. One that caught my attention significantly was recalls and the way that recalls, medical device recalls, were being communicated in the industry. And after a little bit of digging, I found out that that's being done via paper. And it's pretty lengthy and slow and obviously causes issues and creates problems also for patients. So I decided to start Notisphere. That was kind of like the result of me landing in California, is that at the end, I end up running a startup, which probably is fairly common in California, I guess. But what we're doing now is we're working to solve that problem of recall and supply disruption communications, and working to save or help providers reduce the effort that they spent on these things by 80%. And the same for suppliers, right? Creating a safer process. Ultimately, it affects patient safety, which is why I think it's a very important thing to solve. Thank you.
Thanks, Guillermo. And Guillermo and I have known each other for longer than we care to admit, and have been working together in various projects doing disruption for many years. So glad to have you as a part of this panel. Samira, would you like to go next?
Thank you, Brian. So it's a pleasure being here with this esteemed group. I'm Samir Kamar. I am a family physician by training. My background, my father was a diplomat for the United Nations. So we lived in many countries. I'd been to over 100 by the time I turned 18 and spoke 6 languages fluently. It exposed me to many different cultures as a patient, because we would have doctors wherever we were. And when I was growing up, like most people who are from India or that part of the world, the parents had sort of put me on this path towards medicine. I was hoping to practice in the same manner that our expat doctors practice. But when I was in the middle of my residency at Penn, I realized that the way medicine is practiced here is very different from the way it is practiced in other parts of the world. So I started looking at different models of care that would allow me to spend more time with my patients And I came across a very new concept in the early 2000s called concierge medicine, which at that time no one had heard of. But to me, it was very similar to the way I experienced care as a child in Europe or in Asia. So I decided to start the first one of its kind in Central California. I ended up creating a membership medical practice, became the house doctor for the Pebble Beach resorts, ended up becoming the resort doctor for many different establishments. And then I opened up offices in Monterey, Silicon Valley, and in Las Vegas. This whole session is about disruptive innovation. So I think it's safe to say I saw what I was doing with creating a membership medical practice that catered to basically the rich and famous. And I saw an opportunity to disrupt what I was doing again by taking that same model, shrinking down the membership fees to cater to a more, I guess, a bigger audience. And in this case, during the 2009 recession, we launched MedLion, which was the first direct primary care practice in California. I ended up then growing that to 30 states with about 450 doctors working under us, bootstrapped everything. And we essentially became one of the first and biggest direct primary care companies in the US, which basically provided limitless primary care services for a small membership fee, much smaller than concierge medicine. And that model, I'm happy to say, has taken off in many places around the country. Well, then the ACA happened, and it actually helped shift our sales to the B2B businesses who now had to get insurance to stay in compliance with the ACA. They didn't really just need a health plan or a medical office that we were. So we pivoted to a virtual primary care model. We ended up becoming one of the first virtual primary care companies in the US on a national scale. And we did it at even a lower cost. We disrupted ourselves again by lowering the cost to just $10 a month for unlimited primary care. We felt that we could create revenue at scale. While I was doing that, I got invited by Google to pilot their telemedicine programs for the state of Nevada. I had moved here since. And I realized during the work that there was something critical missing in telemedicine, which was basically the gathering of patient data and examinations. To me, as a physician, I can't even graduate from medical school without knowing how to examine a patient or get vitals. And if you were to come into my office here in Summerlin, Las Vegas, you would expect at least for me to look down your throat if you had a sore throat, or get your temperature if you had a cough. Yet Google and other big companies were completely dismissing that critical component of medicine in this thing now that they were calling telemedicine, which to me was just video chat. So I ended up inventing a medical device that was essentially a computer mouse that would allow me as a doctor to examine each of you watching this online right now, right over the internet. That device became known as MedWand. We raised venture capital for that. I was running two companies simultaneously. I learned I am no Elon Musk. It's very difficult to do many companies simultaneously, but I am proud to say that during the pandemic, as its founder and CEO, we were able to raise the venture capital, grow the engineering team, and get FDA clearance during the pandemic, which was no easy feat. Since then, I have left MedWand. I have moved on from MedLion to create something bigger. And I'm taking the experiences from what I've done over the past 20 years, and I'm trying to create a new healthcare delivery system that is currently in the works. More to come on that later, but that's my story.
Thanks. I actually had not realized, I don't think it came out before, your father was a diplomat with the UN. My father was a diplomat with the State Department. So we'll have to chat about that sometime. But thanks for sharing your background and your experiences. Dinesh, go ahead.
Thanks, Brian. So my name is Danish. I am, like Samer, a physician. I trained at Penn as well, which is funny. And I did medical school at Penn and residency at WashU in ear, nose, and throat surgery. I am a serial entrepreneur. My first company was Schoology. So if you have little ones, you may have heard of Schoology. We're in 55% of schools in America, 20 million users in 130 countries. And we were acquired by PowerSchool in 2019 and then went public. I quit medicine that day. Not surprising to the other doctors who are listening. Beyond that, my most important job was that I was actually a caregiver for my father. My dad came to this country with no formal education, worked in a factory, worked his way up, we went from one neighborhood to a better neighborhood to a better neighborhood during the course of my life. And all three kids went to Ivy League schools. Literally the brown American dream. Like that's like the American dream. Unfortunately for my dad, while he had access to health insurance, my dad did not have access to good health care. He ended up, because of something that was completely treatable and easily diagnosable, which was sleep apnea, my dad ended up having his first heart attack at 53. He was bedbound by the age of 60, and I was his caregiver for the last 9 years of his life. And along the way, all of this stuff was happening while I was trying to be a doctor, trying to be a surgeon, a young attending at one of the biggest health systems in the world. And then I had this opportunity to go and build something different. There's nothing more frustrating than being a doctor and a caregiver at the same time. I can promise you that, because the system should work better. And if my dad, who was being treated by the system where I was a surgeon, was getting the care in the way that he was getting, there had to be a better way. There's no way. Can you imagine what regular people are going through? And that was when it really hit me. And even though I'm an ENT, I wanted to go back and kind of rethink how care was delivered. So we started Resilient Health. Resilient Health, the basic premise is that today, when you think about these new models that are popping up, you have virtual care when appropriate, in-person care when appropriate. We know this to be true. The future is hybrid. If you're listening right now and you don't think that the future is hybrid, I'd probably close and move on, because you're going to hear a lot about this. The future is hybrid. There's going to be telehealth when appropriate, in-person when appropriate. What we do at Resilient is that when we talk about in-person, even when you go in person, the doctor's actually on the screen. And all the tools across 73 specialties are connected to the internet and are streaming through Resilient to the doctor remotely. So as we build more locations, not only can you get your doctor at every location, but you can get every doctor of every specialty in our network at every location. So you go in, let's say you have something abnormal, we get a specialist to weigh in same day within 4 hours. Imagine a healthcare system where you literally didn't have to wait anymore. That's what we're building. We've seen thousands of patients. Our Net Promoter Score is 92. We're growing into 5 states, and we're doing this completely outside of the traditional healthcare system. We're going directly to the payers. We're going directly to health plans. And so I will give you a heads up. I am probably the most opinionated person. It all feels like we're sitting, you're going to see today, I talk like we're sitting around a table at home arguing. So you're going to see how this goes. I just wanted to give everybody a heads up. I might seem nice now, but you might think differently of me later.
I think that this is true with the whole panel. Yeah, to get us started, I was thinking about this, and you can see a little bit of the background of the people who have been. Each of their cases have been a part of the system, working for healthcare providers, and are now each trying to disrupt the industry from the outset, and experiencing both the rewards and the challenges that go with that. And that's part of what we'll talk about today. As get started, talk a little bit about what disruption is, because I think I was thinking about this a little earlier, and why this is important. Why does our industry need disruption? I was thinking about this, and I think when you look at healthcare and disruption in healthcare, it's more than, I used the word change before. It's more than change. It's to some extent breaking the process, trying something different. And I think that we have an interesting dichotomy in that this is an industry that is naturally conservative, in that we have patient safety issues and patient concerns. And as a result, we're more reluctant to try things that are new. However, at the same time, the entire growth of our industry is based upon trying things that are new. If we did not try new things, we wouldn't have penicillin and vaccines and endless counts of different things. Our innovation in our industry requires disruption. And I think that that's an interesting dichotomy. So to start with, I think it'd be interesting to panelists to share, what does disruption mean to you? And why is it important for this industry to think in a disruptive way? So whoever wants to take that first.
I'll take it if you want, Brian. The way I see disruption, for me anyway, is it's not, I'll start with what it's not. It's not an incremental improvement of a process or a thing, right? Like the word disruption absolutely means you're just, you're wrecking whatever process is in place today and replacing it with something new. Replacing not necessarily at 100%, right? It could be, like Danish was saying, a hybrid model, right? Where things, I'll use an example of this. Uber came out and totally disrupted not only the taxi industry, but also the car rental industry. Now, those two things still exist today and are being used today, but it's changed the way we actually move around, right? I don't rent cars anymore when I travel because I can Uber everywhere. It's actually less of an issue, right? It's more convenient. I don't even have to carry a card with me to pay, those kind of things. So that changed entirely the way this thing was being done, right? And I do think disruption is needed, especially as we see, to your point, we all, I think, acknowledge that there's a lot of change needed in the industry. And for that to happen, you can't be doing it just slowly with small increments of efficiency, right? You need some serious disruption to change the game. It's the way I see it.
Thanks. What do you want to add to that?
I'll just say, when I think of disruption, and I know this because I've disrupted my own companies many times, I think you look at it from the perspective of just human beings in general. I think, we're all people at the end of the day. We value convenience. We value cost, affordable cost. We value access. And if you apply those three principles in any new product or service at the bottom of the market and move up quickly and relentlessly in pursuit of pleasing those people with those either cost or convenience or access, you end up removing the incumbents. They're not thinking of this anymore. They're no longer startups. They can't move fast. They can't think fast. Big committees, big budgets. And then you have a company that had trouble getting venture capital like Airbnb, literally coming in and disrupting the entire hotel industry, or they almost said Uber with the taxi and rental car business. If there is any industry in this country and others that could use more convenience, better access, and better cost, it's the $4 trillion healthcare industry. And that's why we're all here. So those are my thoughts on disruption.
Well, I'll add to that because you hit something interesting as well. It's not just startups that are disrupting the industry. It is also large companies that are attempting to disrupt the industry with mixed success. Amazon's, Walgreens, Google, everybody's got plans to get into the industry and change things. To a large extent, there's an aspect that it's coming from these larger tech firms, it's coming from startups, but the healthcare organizations themselves, they're the ones who are a little more static. Right. And ultimately they have to adjust to the market and the needs of the market and the changing needs of the market. And I think it's also interesting that, the pandemic maybe accelerated disruption, but these aren't issues that didn't exist before. Like a lot of issues with the pandemic, it reinforced and doubled down issues that already existed, made them more apparent, and made the need to change more urgent. But ultimately the issues are always there.
Brian, I think to that end, I think one of the roles or one of the kind of the key plays that I see from the incumbents and the large corporations, and by this I don't mean the the Amazon's trying to change healthcare, et cetera, but rather the folks that are already kind of embedded into our system today, be it through the financial aspects of it or otherwise, there's a resistance and a fight that occurs, right? So again, if you go back to the Uber example, the first thing that happened when Uber came out and started succeeding was that the taxi drivers started banding together and trying to lobby for rules to not allow Uber, for example, to go pick up people at an airport. This happened in LA, by the way. It happened in Spain when I was visiting, right? There were all these moves to try to just stop that innovation because those folks were more worried about what they were going to lose that rather than solving a problem for their clients, right? And I think this is happening today as well in our industry, right? And there's I think in some cases, the large corporations that do try to change things, they're trying to make really big changes really fast, and they do bump into some of that resistance, right? And lobbies and all sorts of different things. So that's also part of the ecosystem, I guess, that we deal with.
So I will have a slightly different opinion. I actually don't think that disruption is going to come from where we expect it to come. It's very obvious to me that multiple big tech companies have tried to come in and say, we're going to solve healthcare. And healthcare is still unsolved. I don't know if you guys disagree, but there's still a lot to solve. Yet they come in, they try to do something from first principles. And what they don't realize is that the incentives in healthcare are completely different. That doesn't mean that healthcare is good and tech companies are bad. That is not the case. What it means is just like the solution for Uber did not come from a tech company building an Uber. It comes from innovation at the ground level for people that understand that industry. And I think that ultimately what we're going to continue to see is that there's going to be disruptive innovation that occurs at a very, very microscopic level. And it just kind of expands in its, so, I was talking about hybrid care. Hybrid care is so much more disruptive than telehealth was because you can do so much more. And as you start taking over so much more of the patient experience, now your hybrid primary care provider, like the One Medicals, the Resilience and others, like people like us, we actually figure out who ends up at the big health system. That's kind of scary for all you executives. Imagine we had 100 clinics in your market and you had to rely on us for referrals. I won't give you any, just kidding. But it's, ultimately you're reliant now, right? And so all of this disruption has to happen at like a ground level. There's a really good approach that I was taught by one of my mentors, which was when you're building something disruptive, the number one key is to find the perfect problem. And he had 2 criteria for the perfect problem. He said, number one, the perfect problem has to be something that all the customers here, let's say patients, agree is a real problem. And number 2, it has to have a solution. So for example, cancer, I think everybody here agrees it's bad, not good, right? But not everybody has a cure to cancer, except Carl June maybe at Penn for a very select few, right? And so the idea here is that it has to have both. When you solve that one problem, the best way you know it was the perfect problem is that you've now created 10 new problems. And as you solve those 10 new problems, now you've created 100 new problems. So exponentially, the number of problems are increasing. Does that really sound like a solution that your incumbents or the big tech companies would want? They don't want the noise. But when you're a little startup, right, you love that because you now have more. And all the interconnected solutions, that's your moat. So, that's the moat that you're building because somebody has to go back to the original perfect problem and try to solve it and work through it. So some big company can't just buy their way in. They have to live through that. And that's something that is truly disruptive. Clayton Christensen used to talk about this. It all happens at that first level. And neither the tech companies can do it directly, no matter how much they try. By the way, build by partner, right? I think I mentioned this in the pre-call. Build by partner. Every consultant puts it up there. All you executives have learned about it. You know what tech companies are doing? They tried to build, it didn't work. They tried to partner, it didn't work. Now what are they doing? They're just buying. That's all that's happening. When we look at executives on the provider side, I'm just not convinced that they're going to be able to build the disruptive solutions of tomorrow. I think the question is, are they going to be able to partner? Are they going to be able to buy? And to partner, are they going to be able to sacrifice their heads in beds mentality, the fee for service mentality, the approach that they're taking to care? And I'm just not convinced. It's too hard. It's because there's too many decision makers, too many hats. And so maybe there is a different approach here, but disruptive innovation really requires going back to the basics, and it's really, really hard.
There's a comment in the chat that disruption innovation is not always a positive outcome. And I think that's an important point. It's not always going to succeed. It's not always going to be the best answer in the end. You hope it is, and ultimately you have to try different things to get to the best possible outcome. But your point about the tech companies, I think the interesting thing is that you have companies like Amazon, because if we were having this discussion 2 years ago, there was a lot of talk that Amazon's going to take over the healthcare industry, and it probably would have been a big discussion. And I think that companies like that came along with the thinking that if we partner with big companies like Berkshire Hathaway, we throw enough money at this, that we can find a solution. And a concept that you would think that enough money would solve some of these problems. But the reality of it is that in the end, many of these partnerships, I don't want to pick on that particular one, but many of these partnerships, many of these companies didn't end up doing anything all that different. And in some cases didn't do anything like what we expected the change to be. And so, I think part of that is recognizing that that the bigger you are, to some extent, the more challenging it is to do something completely new and completely different.
Yeah,
so smaller companies can take bigger leaps.
I do want to say something. I'm reading some of the chat, which I probably shouldn't be doing. And I'm going to tell people it's totally fine for people to want to be Sears, because Sears was nice and pretty and felt good. But, Sears is gone now. So in reality, you either have to ask yourself, either I disrupt the right way or I get disrupted. There's only two options now. Healthcare now has a digital infrastructure. The game has now begun. And I think that changes the propensity for disruption. It took a lot longer to get here. But like Brian was saying, something happened during the pandemic. It's like a change that's happened. The consumer changed their expectations of healthcare, and now the providers can't fight back, in my opinion.
But you brought up the Sears example. I think the important thing about that is that you have to continue to be a disruptor, right? Sears was a disruptor. They sent out catalogs to people and disrupted the whole industry 150 years ago. They just stopped disrupting after that, right? So you have to continue that. But I just think that what you're talking about, that part of that is that it has to be continual. You have to try different things, and you have to never be satisfied with the status quo. But I apologize, Guillermo, you wanted to jump in there. Go ahead.
No, I was just going to point out, first of all, I didn't mean to work up Ernest with the Uber example, but so apologies. But the way I see it is, and it's just an example, right? It's no different in Tesla. But here's where, I agree, disruption not always has to be positive or have a positive result, right? We're all considering these things now with AI, for example, where people are saying, ringing the alarm bells, going, this could turn into a really bad mess, and it is disruptive, right? But the way I see it is, we also have, and this probably is part of a barrier, a psychological barrier to disruption to some degree, right? When you look at Tesla and you look at the amount of noise that gets created when a Tesla car crashes or runs somebody over, the amount of news we get and the amount of concern that the market shows, without ever considering the fact that there are tens of thousands of people getting hit by regular cars driven by regular people every day, and we don't seem to see that in the news at all. Right? The idea is disruption also means, in some cases, there is a concentration of influence into one element. In this case, it could be Uber or Tesla or Airbnb, et cetera. And so the regulation shows up, right? Ernest was actually talking about, in some cases, the concern was safety for the folks riding in an Uber, right? Those concerns still also exist with a taxi driver. You know, those things are still there. You know, try to get a taxi in Turkey one day and at night if you're a female, you know, and see if you're scared or not, right? Or if you're concerned. So for me, the key is we need to somehow learn to embrace the fact that, yeah, there's going to be some ripples and some wrinkles, right? Nothing's going to just be smooth and perfect. But we also need to come to accept the fact that the things that are happening today are not nearly as perfect as people sometimes want us to think, right? That I think is kind of the push for innovation that we're all hoping for, right? For disruption is we understand that some things are great and others not so much, and we need to change them in order to solve these issues.
The point you brought up about, you know, maybe almost like held to a different standard. The rest of the panel, do you feel that way sometimes, that disruption gets treated unfairly, that you have to be perfect?
No, not really. Not in my people just expect so little. It's like my marriage. It's like, you know, the expectations are always so low. I've set good low expectations. Everything works out in the end.
I think disruption has to be looked at as you have to sort of think about the reason why you're disrupting something. Some things don't need to be disrupted. Others do. And, you know, for an entrepreneur like myself, when we're trying to create something new, a new product, a new service, and those of us who have raised venture capital, we know this. We have to specifically identify the problem that we're solving for. Because what if you're solving for something that nobody really cares about? Blockbuster was pushed aside because they didn't think people would ever stream videos or movies online. And when Reed Hastings made this, he was ahead of his time. He figured that with the way technology was growing, eventually you would be able to stream. He wasn't there yet, so he started shipping DVDs or CDs, what do you call it, these DVDs to people to watch on at home. And that just morphed into his vision, which eventually came to fruition, and now Blockbusters is no more. I think we have to, for the sake of progress, for the sake of society to improve on itself, we have to keep pushing the boundaries. And some are going to fail, like that unfortunate accident in the Atlantic that we heard about a few hours ago. But now we know a little bit more about submersibles that get down to 13,000 feet and what happens at the cost of a few lives, unfortunately. But if we don't push the envelope, if we don't push the boundaries of what we can do, we're never going to improve. We're never going to create a new wheel or levitation or getting to Mars, finding new power sources, X-rays, CT scans, MRIs, PET scans were all created on the same premise in the pursuit of a better life for all of us. And I think that's what a lot of disruption is really about for me. And to answer to your earlier point, Brian, it does get sometimes unfair. And that unfairness, I think, is led by the incumbents, by folks who are appropriately interested in self-preservation because it's working great. Hospitals are making a ton of money billing the way they are. They don't want that to change. Insurance companies' premiums are going up year after year after year. MLR ratios are all upside down now. Consumers worry about increased premiums. Do you think that the insurance industry is as concerned? I don't know. I don't think so. And that's where the disruption needs to happen. Society will sometimes tell you, enough, we can't take this lack of convenience anymore, this high cost anymore. We need a better way. And that's where the disruption comes from, either from startups or incumbents themselves sometimes.
Why is we've talked about a lot of examples like Netflix, and I think all of us still have an unreturned Netflix DVD at home somewhere. You know, and we've talked a lot about you know, different kinds of industries. Why is disruption hard in this industry? What makes this industry more challenging or different than others?
I have a quick theory I'll share with you, and this is something that we're telling our investors these days as I build my next company. Clinicians, sorry, Danish, I think you're involved in this. Clinicians by training, we're scientists. We were trained from medical school to focus on the science, to focus on how your body works, how to address ailments, how to treat pains, alleviate suffering, hopefully cure some diseases. But we try very hard, and we spend a lot of time in school doing that. We are taught nothing about business. We are taught nothing about insurance codes. We don't know anything about prior authorizations. All those things are foreign to us until we get out into the real world and start practicing. And that's when we realize, oh my goodness, this medicine is not what we envisioned. We have to actually do other things. And a big part, and Danish alluded to this earlier, I think a big part of the challenge is a lot of the frustrations come from the clinic side. And people who try to create better systems in healthcare or try to disrupt in healthcare are doing it not from the clinician side, because we don't have time for that. They're doing it from the patient side, on the other side of the exam table, because a lot of technologists, a lot of businessmen, a lot of insurance administrators have been patients. They think they can solve the entire healthcare system from their side. That's one issue. The second is you have a lot of vested interests in the complex web of healthcare. And I think, Tesla made news for going directly to consumers and selling Teslas in malls. What did he really do? He cut out the middleman. I think there is no industry more than healthcare that has more middlemen and middlewomen than healthcare. There are a lot of entrenched interests that don't want to see this thing change. And I think those models where you do go directly to consumers disrupt the situation. You're going to have different kinds of insurance companies coming up later, different kinds of healthcare companies like Resilient. And I think that that's a big part of the issue is it's very challenging to get all of the competing factions at the table to change something, because it's like it's a domino effect. You change something for one party, the other party gets hurt. If you change something for that, the other one gets hurt. And so it's kind of hard. So what do? You can't build on this. You can't change this. You have to completely wipe it off the table and build a brand new healthcare system. That's the way you do it.
And what's fascinating is even when you look at, again, I don't want to pick on anybody, but the commentary, if you work at a provider, who do you think the bad person is? The payer. If you work at a payer, who do you think the bad person is? The provider. The system is symbiotically in hate for each other. This is like a symbiosis of BS, in my opinion. And ultimately, what we're seeing is the people at the top that are pulling the strings. They are working together and they're colluding, and the people that are actually taking care of patients are getting left behind. And they just want to argue about it. They're like, oh, the payer's so bad. Yeah, but as medical loss ratio goes up, right? As MLR goes up, who do you think that money is going towards? Providers, right? And medical loss literally means the money is going to providers. And so it's in symbiosis. And, one thing I will say, what Samir said about doctors, I think it's also doctors, it's been beaten into us that we're bad at business. Like, it's like, oh, you're just bad at business. We solve problems all day, right? Like, it is possible that if we were trained on it, we'd be better at it. And any doctors that are often become really good at business. So it's like this really interesting problem where, people that are on the front lines taking care of patients are completely disconnected from any sort of connection to the actual solutions, like Samir was mentioning. But I also think there's another bigger sort of issue that some people have brought up in the chat, but I wanted to put something out there that I think a lot about, that keeps us up at night at Resilient. And I think most companies that end up succeeding and not going down the road of being the next Cerebral or the next Theranos, they're thinking about this issue, this tension. There's a tension in our industry that we need to think about, which is, if you guys know Facebook, their motto was move fast, break things, right? So you've got move fast, break things. That's the tech motto, all right? And then the other side, what is the medicine motto? First, do no harm, right? They are literally at odds with each other at some level.
Yes.
And we've got this huge tension between the two. So you as a health tech entrepreneur, especially if you're a physician or have a physician on your team, this is something that comes up all the time, which is, hey, we want to try this new thing. But it's not been tested really. Okay, let's figure out how we can test it in a simulated way and figure out how, and it, you can't just break things, upset people and be like, oh, we shouldn't have done that. Oh crap, we got to go back. You can't do that iterative, really fast, move fast, break things stuff in healthcare, which slows down innovation. But again, the concept, healthcare is an inelastic good. When you're sick, I'll tell you, even as a doctor, when I was taking care of my dad, when my dad was like, they were saying, hey, maybe he needs to go on dialysis. And I was like, oh, I don't know. Like, these are like big consequential decisions. I'm sorry, but changing your profile photo on Facebook is not as important. Right. And so we're literally dealing with people's lives and their health, and every decision has this like ton of decision tree stuff. And so that's in my opinion, there's like this underlying challenge in healthcare between those two things. And I don't think we can forget that.
Danish, I think
Oh,
I agree with what you're saying, but I would add a little bit to it in that I don't think it only limits itself to the clinical side of things, right? When you think about it, I totally understand the concept of somebody saying, I don't want to harm a patient, and I don't want to do anything that's innovative, but if it's going to have, as a result, the chance that I do something that hurts somebody, right? But when I look at supply chain, for example, I'll tell you that they're just as risk averse, right? There's no patient there at risk, but the resistance to adopt innovative approaches to things is just as low, right? Just as high. I can't tell you the amount of times that I hear the phrase, who else is doing this? That's it. Who else is doing this? Right? That's the number one killer of innovation right there. It's basically people saying, I don't want to take this step. I'll let somebody else do it. Right? Now, if you think about it, for me, that's terrible, right? Because I'm trying to change the entire way the industry does this. And for that, I need providers and suppliers to move, right? Manufacturers to move. But if everybody starts saying, well, who else is doing this? You got this loopy loop where at the end you get nowhere, right? It's taking us a lot more effort than I would have hoped. So we're making progress, but it's not an easy progress considering the obvious benefits to what we're proposing, right? I mean, in some cases, it's crazy that you hear things like, this is absolutely needed by the industry. I absolutely am with you guys. I'm very supportive. What you guys are doing is great. Call me when everybody else is doing it, right? That basically means that we have to start looking at the fact that not everybody has an entrepreneurial spirit or an innovative spirit or a first mover kind of mentality. Today, I would say in supply chain, you have when I look at providers, for example, you have about 5% that are the first step takers, the guys that'll just go, we're going to do this because this is what's needed. Then you have about 15% that look at those 5 and go, well, a year later go, well, if they're doing it, I'll do it too. And then you have about 80% that literally they will just do it when they have no other choice because it's so obvious that it's the smart thing to do, right? That's a problem with innovation. I think speed is also a variable we need to look at, right? Disruption means fast. Disruption doesn't mean it'll change over 100 years, right? When I look at when I look at what we're doing, the fact that today, the way that the industry communicates these recalls is based on methods defined in 1970s, in 1976 to be exact, right? Nothing's changed. Still doing it. Kind of crazy, right? And
there's a couple of things that you guys mentioned. I kind of want to zero in on. One was kind of earlier. The idea of one of the first questions that comes up is is it going to get reimbursed? Who's going to pay for it, right? And I think that a lot of our audience is probably in finance or related roles and in different executive roles within hospitals that are a part of that kind of conversation. And I think telehealth is an interesting example to look at. As something that was very recent. Nevada was actually kind of ahead of the industry to a large extent, in that we were one of the first states to have price parity on telehealth. One of the big challenges with telehealth from the beginning was, all right, yeah, it may be more efficient, but if we can't get reimbursed for it, then we can't offer the service. And that was something that the pandemic changed the conversation on. But I think that's a big challenge. Let's zero in on that. I want to get into some of the other things you guys mentioned too. Let's zero in on that problem for a second. How do we address the issue of the fact that that ultimately providers need to get reimbursed for the services they provide. And to do that, we have to convince insurance companies that it's worth paying for in our fee-for-service world.
Sometimes you have to change the whole game. When direct primary care was introduced, it still hasn't gone mainstream, I would say. It's still a niche market, and it's growing very slowly, but I think it's going to continue to grow. The direct and direct primary care was a direct financial relationship with primary care. There's no coding, there's no ICD-10 codes, none of that. The patient simply pays for service, and that's it. You get your service. If you don't provide a good service, the patient goes somewhere else. It's that simple. The two most important people in the exam room are the patient and the clinician. Yet we have all this paperwork that puts barriers in between us and the patients. A lot of those barriers can be financial. So I am of the mindset that if you think about what the biggest problem in healthcare is today, if you were to ask 1,000 people on the street, I'm pretty sure, I'm not a betting man, but if I did bet, I would bet that they would say the cost of healthcare. It's continuously going up. And the reason the cost is going up is because the way the system is set up now financially just is not sustainable. You can blame Medicare for setting those rates. You can blame insurance companies and their MLR ratios, whatever it is, it's not working. So trying to put lipstick on a pig is not going to work. You can't take a pig to the ball. It's still a pig. And you have to create a new financial incentive system, a new reimbursement system that is completely different from what we have today. Some of the more newer startups, including my own, don't rely, for instance, on insurance payments. We don't rely on ICD-10 codes to be able to generate revenue and pay our doctors. We believe that a new reimbursement system has to be created. Now, are we going to work with hospitals and insurance systems? Absolutely. We have to, because 250 million people in this country use insurance or Medicare or Medicaid. So we have to find a way to work with that. But that doesn't mean that we have to stay there forever. I do think that the way to change this is to create a whole new financial reimbursement system for doctors and for other care providers and institutions like hospitals.
You know, Brian,
Sorry, go ahead.
I'm sorry, go ahead. Go ahead, Danish.
I was gonna just say something really quick, actually. Reimbursement's pretty critical. I think for people that are thinking through it, I agree with Samer. So for Resilient, we go directly to the health plans and partner with them. We do actually keep ICD codes and all of that stuff, so we do zeroed out claims so we can show ROI for the health plan. But the doctor's not doing that, actually. We're automating all of that. So on the back end, using a bunch of tools, because the doctors are not, they don't want to focus on that. They want to focus on patient care delivery. I think the reimbursement part, though, is very important. Too many entrepreneurs that came from outside of healthcare tried to solve, again, first principle problems without figuring out the principal agent problem. And the principal agent problem in healthcare is real, which is we have three players: the patient, the provider, and the payer. The payer, most patients, unfortunately, have been convinced that they need somebody else to cover the bill. And that has been drilled into them over the course of a very long time. And so they'll say, well, why don't you accept my insurance? And you say, well, that's not how the system works. They're like, then why am I paying an insurance company? And you're like, well, it's required by law. And it's like, it's a whole circular issue that we've gotten into. And so, the key is to try to disrupt it without disrupting the principal agent problem. To Samer's point, DPC has been around for some time. I was just looking at the numbers this last week for a meeting. There's 5,000 of them in the entire country at this point. They're pure DPC. There's a lot more doctors out there that are not doing DPC than are doing DPC. Now it's accelerating, it's getting better, there's better infrastructure. But there has to be a middle ground here on the payment model. And I think reimbursement is actually kind of critical to figure this out. Value-based care, some people are saying that might be it. But like I call value-based care the Web3 of healthcare. It's like, maybe crypto will be something someday, but like it's not there right now. That's how I think about value-based care. And so it's very interesting to see whether we're going to get there. There's no doubt that we need payment model disruption, just like we need provider model disruption. I just don't know what the answer is yet, and I think it's too early to tell, but something's coming. It feels like something's coming. Everybody's seeing this. There's going to be some disruption.
Well, I think you mentioned the three pillars: the patient, the provider, and the payer. And I think one thing that's changing is that in the industry, the patient has been extremely passive in that process in the past. They're told where to go, who to use, what they should do when, what information they should have, what information that they're not in charge of their medical records. All of that, I think, is starting to shift. And the patients are starting to take a more active role. And maybe that's a part of that disruption. In the end, if the industry doesn't disrupt itself, eventually the patient will disrupt it for them.
I think regarding that, that's an interesting concept, right? Because every time I hear folks talk about patients kind of pushing for the change or leading the change, I can't help but really think, okay, we have again a 5, 15, and 80% setup with patients, right? I mean, the amount of knowledge and research that you need to do as a patient today to navigate everything that happens to you as a patient, and by happens, I mean even getting the bills for stuff that you thought you wouldn't have to pay for, or these things. The 80% don't know. The 80% will just face it and either pay it or go broke or whatever, right? But they're not actually, I don't think that they don't have the ability today to do it, right? I mean, I'll give you an example of this. My wife got a colonoscopy a few years ago, and it was supposed to be, it's preventative, it's supposed to be covered by insurance. Therefore, it was free. It was supposed to be free. And I get a bill for $1,800, right? And it all boils down to, they found a couple of polyps. The physicians charged it or coded it as diagnostic because they found something, right? Now, I told her, call the doctor and tell them, no, that's not how it works. You don't get to change it in the middle of a procedure. Well, she goes back to me going, they're saying no, they're saying that's the way it is, right? And I said, well, that's not the case. And she eventually goes, well, you deal with it because you know about healthcare. So think about it, right? It took me 3 months, by the way, to actually get it corrected and not paying, right? But what I was telling my wife was how angry it makes me to think that there are folks out there that have absolutely no idea that that is wrong and will end up paying it, or they go to collections, right? They're sent to collections or something. That shouldn't be happening. And the problem is those folks cannot possibly push for the change because they don't know, right? It's kind of like a little tricky situation, I think. I think what needs to change in this case is you almost have to have regulatory help in some ways, or in other ways, the ability to disrupt or rip out the model that we use today, right? In some way, I go back to the stuff I deal with, and you realize when I asked actually, why is it that the FDA regulations around communicating recalls hasn't changed since 1976? The answer was they need approval from Congress to change the regulations book. Therefore, it doesn't change, right? Nobody goes through the hassle. They come up with guidelines, right? They come up with guidelines, which are interpretations of what can be done today. But I'll tell you that I've actually heard manufacturers say, my legal is saying that we will only do what the regulation book says. It's their only way to stay safe, right? That's a problem. That's not going to get changed by the patients, right? Those things don't, there needs to be the clarity upstairs, in the regulatory bodies to say, we got to change this, or we got to at least provide the avenue to do it, right? Help some disruptors go through that, I think. My wife is going to be telling me, I can't believe you talked about my colonoscopy. in a panel.
Anybody have anything to add to that? Not about Guillermo's wife, but about the it's interesting, as I look at in the chat, a lot of people are sharing some of their experiences and frustrations with the system that they're a part of too, right? I think it leads to an interesting question because I want to go back to some of the other things, but I think it's kind of an opportune time to talk a little bit about what people can do, right? There's people who are in the system, I think to a large extent, feel that they're limited as to what they can control and what difference they can make. I mean, if you're a healthcare executive right now at a hospital system that has a lot of hospitals, you have some authority, but you can't change the whole system. What can people do from various different positions to change their cultures, their organizations, or be a part of changing their culture, their organization, to be more embracing of disruption and innovation?
I'll tell you one that I have. It's a little bit of a pet peeve of mine. I think, somebody was mentioning in the comments earlier about a top-down approach to innovation, right? So if a healthcare or a provider organization executive supports innovation and kind of approves innovation projects, et cetera, then it gets cascaded down and people then, teams embrace it. I think one of the worst things that can happen today is a misunderstood approach from executives that say, I'll send this over to my team and see what they think. At that moment, what you're really doing is giving the opportunity for folks to say, I think what we're doing right now is okay. And I don't need another thing on my plate. It should be the opposite, right? It should be just, you want to ask your team if the problem exists, right? Ask them, how are you doing this today? Or what are the side effects? Are these things real? What I'm hearing, without even telling them you're being presented with some alternative, right? To validate, triangulate this stuff rather than just put it on their plate. I get the impression that there's a lot of times where things could be changed. And yet what happens is somebody that's already stretched thin and overworked gets asked, do you think we should take this on? And they're going to go, no, absolutely not. I'm fine with what I have, right? I have heard, by the way, and I'll be quiet after this, but I have heard, believe it or not, this is something I heard from somebody, true. Yeah, we have a process. It's a terrible process. It doesn't actually work that great, but it's a process. Period. That was their way of saying, I'm not taking anything new on, right? Even acknowledging the fact that the process was not good. It was like, but I have a process and I can tell the guys upstairs I have a process and I'm already stretched thin and I don't need another project. That happens a lot, I think.
Yeah, I'm a skeptic when it comes to the bigger systems. For one person to come in and influence the entire system to start behaving differently is quite challenging. I think you can start with yourself and hope that it becomes infectious and can start spreading through the culture. But you just think from like the bottom up or the top down, it's incredibly challenging. And it's a multi-year process to change the culture of an organization. I will say there are certain frameworks that work well. A lot of times when you see senior leadership, especially at health systems and at payers, those two main types of organizations, they usually say, okay, well, what's the problem here? And then they end there. They say, oh, okay, well, this is the problem. We got to find a tool to solve this problem. But what they should be doing, it's a really, really old framework, but it's called the 5 whys. People know this probably. But you then ask, okay, well, why does this problem exist? Oh, okay, well, why is that going? You have to come up with 5 questions that go deeper and deeper and deeper and deeper. And what you're going to learn in the end is going to be something completely different than just like saving some FTE hours on one thing. And, when I was at Penn, Roy Rosen, I think he's still the chief innovation officer there. He started instituting that. And Roy is like, he comes from completely outside of healthcare, super smart guy, one of the smartest people I've ever met. And even, he would be the first to admit, and I think he's written an HBR article about how challenging it is to even get a place like Penn, which clearly Samir and I both come from Penn. So it's like funny that like, it's a pretty innovative place. And even that place it's impossible to try to really get into the culture. I'm not 100% convinced. I hope one of you all do it, but I think sometimes it's much more important to realize, okay, what is within my domain and how do I then bring that in, right? Like there's new technologies that are coming every day. How do I do what I can do in my place as an executive and then show those wins, get those wins out there, say, hey, I took this leap and it worked because I made the right decisions along the way. Here's what worked for me. And then kind of sharing those stories internally. Again, I'm not 100% convinced that it's so simple that one person can do it, but it's a worthy, valiant effort. I go back to Sears, having one major senior executive at Sears saying, you know what, this internet thing is like really interesting. Maybe we should, like, how we were the catalog people? Maybe we should put a catalog on the internet. Like, I just don't think that can happen. It's just like, it's not in the mentality. But the best counter example to my example is Walmart, right? They bought jet.com. They are now the biggest e-commerce store that essentially rivals Amazon. So it's not impossible. And for people that don't know, Walmart was the first one to put a computer at the register. That's like their big sort of innovation. And so the idea is that they, like Samer was mentioning how he's reinvented his companies, it is possible. It's just really hard. And I'm just not convinced that it's going to happen. But you guys
Well, I'm going to challenge because I think you disrupted this conversation with a simple answer to some extent. In that, I think there's something important that you mentioned about the questions. You mentioned the 5 whys, right? And maybe to some extent, it's a way of thinking, and to ask the right question, because the wrong question is, what does everybody else do? And that's probably the most, we have this problem, but what does everybody else do? Oh, they're using this software, or they're using this service, because that, I think, is where a lot of people naturally go in the industry. And maybe the first step is not looking at it from that perspective, really looking at the problem, really looking at potential solutions and coming up with new solutions. You want to look at the solutions that are out there because they can inform and drive, but rather than just accepting that just because 50% of the hospitals use a particular solution, that it must be the best, actually determining that it is the right answer, the best answer, and that there isn't a better solution out there, or a better solution that you can create.
Yeah, I think. Sorry, go ahead, Dennis.
No, go ahead. I've been talking for a while.
I was just, in fact, I was just reacting to something you said earlier, right? You brought up the details around other industries and, bringing kind of the attitude and the ideas of other industries into healthcare. I've seen that in the supply chain world. You have Eric Tritch at University of Chicago, for example, who's got a team of folks. Some of them came from automotive. Right. So when it comes to doing, negotiating contracts and doing sourcing and stuff, they started applying, the principles of what I would say is an industry that has, pretty tight controls or processes around sourcing, right? Because they need to have all this stuff almost fail-proof. And it actually works, right? Because those guys start asking questions about, well, why are we doing it this way? And they do the 5 whys. And they have no fear in asking because they haven't been in healthcare for 40 years, right? So it's perfectly reasonable for them to ask. And I think that actually does bring the right kind of, injection of fresh air, I think, where people, in some cases, I think there are a lot of people that are also worried about looking foolish if they try something and it doesn't work, right? The fear of just ridicule, when in reality, what we should be doing is saying, clearly, and that, by the way, is something great in startups, right? When you have people that have started multiple startups, they have no problem telling you, my first 3 failed miserably, right? And here I'm doing this one now, and here's what I'm doing. That's part of a mentality. And there's a lot of folks that don't have that. And I think if we had a lot more of that in organizations in healthcare, where at least people weren't penalized by trying new things, it would go a long way.
I think it's not necessarily important to think about what startups do. We're trying to create magic. We're trying to create new payment systems, devices that examine you over the internet, all sorts of interesting things that push the boundaries of technology like AI and so forth. But sometimes larger institutions don't have to go that far. You just look at what you're already doing. Do we need hospitals? Absolutely. Why then is Nevada ranked where it is? Why is that? Why is it that my VIP patients who I take care of here in Summerlin say, hey, doc, if anything happens to me, can you refer me to the Mayo Clinic in Phoenix? Can you refer me to Stanford? Can I go to UCLA? Why do they ask for that? Well, it's obvious, isn't it? I mean, the care that is perceived and in many cases is proven is superior at those hospital systems. If you want to disrupt something, disrupt your own industry, disrupt your own hospital system. Ask why Stanford gets higher marks every year with outcomes, with discharges, with readmissions. What's happening? Take it down to the granular level. Look at each department. Everybody is where the whole system has to be analyzed. If you can do that and give the folks in Reno and in Vegas the confidence to run to the ER because they know when they're passed out, they're going to be well taken care of, I think you've done a great job right there. We don't have to go so far as to create new payment systems or get technology involved. Those are hospitals too at Mayo. There are hospitals too at UCLA and at USC. There's an old joke that I used to hate, and I think we're making progress here. But when I moved here to Nevada about 11 years ago, they would say, well, what's the most popular place to go when you're ill? They would say McCarran International. And that joke has become infamous in the medical community. I'm happy to say I have lots of friends now who have moved here from California, from Stanford, from Mayo Clinic to Vegas to set up shop. But there really is still no cohesive system where patients can go and get all their care in one place or through one system, which I think makes things a bit challenging. But I think if hospitals, I'm just picking on hospitals right now, if you want to disrupt, do what Stanford does, do what Mayo does, and give the local community the confidence it needs. When it comes to startups, if you want to do something there are lots of startups that are willing to work with you. Make things go faster. Remember, startups work at a very fast pace. At our company, we have to do 5 things every day that increase the valuation of our company. That is the rule. We don't wait 1 month. We have to do 5 things every single day. And if you can match to some degree that pace with startups that may actually help you make more revenue or help you save in a certain area or improve your outcomes, be open to that. And I think you'll get a lot of attention.
There was a comment about AI in the chat and ChatGPT, which I should probably talk about because I think we can't talk about disruption without at least briefly talking about AI, because a lot of people see that as a big disruptor. So I'm curious about the panel thinks, in terms of AI as a disruptive force, is this the ultimate disruptor, or is this going to go the way of the Segway? And I actually found this out recently. The guy who owned the Segway literally died in a Segway accident where he fell off his Segway off a cliff. It kind of fits in probably the ultimate naysayers of AI, thinking that maybe it will take over the world. I follow in that example. But what do you guys think as of AI as a disruptor or as a tool in the kinds of things that you're doing?
Well, I'll just go ahead and start quickly. We are doing a ton of work in AI right now. That's part of the reason we're in stealth right now, because AI hasn't really fully been understood yet by everyone. We're not going for big moonshots. We don't want to replace doctors and nurses, administrators. We don't want to do any of that. What we do want to do with AI is use it to solve for specific patient frustrations and specific clinician frustrations, problems that we have today that can be solved with today's technology. I think AI has a ton of potential. I think it also has a ton of potential to do bad things. You're always going to have nefarious bad actors using tech for nefarious purposes. I'm sure when Ford made the Model T, they probably predicted that the bank robbers would use the Model T to go rob banks. It's what happens when you have new tech. So I think that AI has a lot of potential. I think that technology outpaces tradition. Technology always outpaces the law. You're going to have new laws that are going to have to come about and corral and harness the power of AI. There's a lot of issues now with misinformation, a lot of issues now with people trying to self-diagnose. I think AI can solve for a lot of that. So we are working with it. We're neck deep in it. We believe there's a lot of potential, but it has to be used for the right purpose, and in many ways to protect the patient data. I think that is critical. When you have the ubiquitous floating around of patient data, that's very important. And I'll end on this note. This is something I said at Nixon Peabody when I was giving a lecture at their law firm in San Francisco a few years ago. Everybody on this panel, everybody in the audience really cares deeply about the protection of health data. They care about the security in the transmission of health data. But I can tell you something, pretty sure there's a farmer's wife somewhere in Kansas who doesn't care about that. She just wants her cancer to go away. When I was taking care of millionaires and billionaires in Silicon Valley, they didn't care about texting me specific healthcare questions because they wanted access. This is when the iPhone had just been released. We even had a form for them saying, do you allow us to communicate with you on text? They said, look, we don't care. We just want access to you, doc. And if this is the only way we can do it, so be it. So I guess what I'm trying to say is sometimes we get so caught up in privacy and health data, which don't mind, it is important. It's very important. But a lot of people just simply want access. They want better cost. They want convenience. And so we're using AI to solve for all of that, whilst, of course, still protecting patient data.
Yeah, I couldn't agree more, Samir. I mean, even from a personal perspective, I always roll my eyes when I go to a doctor, new office or whatever, and they give me all the forms to sign so that, and I don't even read them. I'm like, yeah, sure, whatever. I don't care. As long as I don't have to walk my record to somebody else and explain what's happening, right? Today, when you think about it, while you were saying all this, one of the things I was thinking is it's also, when you compare ChatGPT and how they've gone about it, and not necessarily their capabilities, but just how they've gone about it compared to some of the other, solutions and tools and things that are out there that we look at and that we've experienced. The difference was ChatGPT was open to the masses from the get-go, right? It wasn't about squeezing out every single dollar from day one. It was more about, let's show what this thing can do. Let's show everybody what this thing can do. And in fact, what they have right now is an ecosystem of all these plugins that you can use with ChatGPT. And it's growing every day. So what they've really created is an environment for innovation using their engine and capabilities, right? Meanwhile, you look at, different EMRs or whatever, and somebody had a comment earlier around interoperability. And, if I go to somebody that's using, that has my chart, and they're sharing data with somebody else that's using my chart, great. But if I get referred to somebody that's not using my chart at all, right? They have a different solution and it's not Epic, then I'm out of luck. At that point, we're back to, can you fax this or can you send it over, right? And by the way, because of what you're saying, a lot of times that doesn't happen. An example of the sleep study that I had, that where at the end I ended up having to call several times and then getting somebody to send it by mail because they wouldn't actually email me my study. Because that was against, the whole thing is kind of crazy because people are obsessed with this, right? Which I agree with you, it's very important, but there should be a way to ask a lot of patients very quickly, can we maybe include you in a different layer where this is not important to you at all, right? That would help, I guess.
Yeah, I think we also have to understand what's happening in AI right now. So a lot of people see, there is the ability to extract information from a bunch of different amount of data. And then the second, that's been around for some time, actually, the ability to extract information from multiple sources of data. The second part is the crazy part. This is where the magic is happening, which is then generating something. Like, it looks like it's like out of like the thin air. It's like kind of out of nothing. And that magic is what is the new aspect of what this generative ability for it to mimic and emulate what we would do with it. That is what's incredibly interesting. So, I'm sure you've heard, people have heard this adage, but it's people overestimate the short term and underestimate the long term. So, one of the examples that we were kind of talking about, in the short term, the reason why ChatGPT could do it, right? You couldn't bring it to healthcare, for example, is because it was wrong like 30% of the time, but it was right 70% of the time. Think about how crazy that is, and the fact that like you put something into a thing and it comes up with something, and 70% of the time it's eloquent and interesting and smart, and it seems like it's like a human talking to you. It's crazy, right? That 70% magic was worth the 30% hallucination, and that's been such an you could never do that in healthcare, right? First do no harm, move fast, break things, first do no harm. And so like, you're kind of stuck by that, and it's okay because it's healthcare and it's people's lives. So for people that are thinking about, well, how do I think about AI? I would think about AI the way you think about the internet. That's how I've conceptualized in my head. You don't ask the question, how do I include the internet in my strategy? Right? Like, it's not the approach you should think about. Like, it's kind of like, in my opinion, kind of foolish to think about AI strategy. That's not how I would think about it. I would think about it as, oh, this is the new pipe. Like, this is my new utility. I have this new utility, like electricity and the internet and water. Now I have AI. And that's, so, when we're thinking about our strategies, every single one of our employees is using AI for a different reason. And they're solving their problem using AI, and we encourage them to solve their problems using AI, but still have human in the loop. So the thing that's exciting about AI is not the neural net side. That's been around forever. So there's two parts to it, right? There's a deep learning part, which is it's taking all the information that is got available to it, the training data set, and then using that. And then the second one is the crazy one. The first one's been, neural nets and deep learning's been around for a while. The second part is a crazy one, which is reinforcement learning with human feedback, RLHF. And obviously there's a transformer component, which then that pumps out the solution. But the RLHF is kind of crazy. So every time you're interacting with it and you're giving it more information about what you want, and you keep correcting it, it gets smarter for you as an individual, right? And so again, the way I would think about it is, when I was younger, you'd be on the internet, and then if your mom picked up the phone, I'm a little bit, I'm aging myself a little bit, but your mom would pick up the phone and you'd be like, Mom, stop, I'm on the internet. Like, that was the reality of what people went to. And now look where we are today, right? And so don't think about AI the way you think about it right now. We are like at the beginning. This was the first time that AI actually feels useful for the average person. Now it's becoming a utility. So don't think about where we are today. If at that time you knew that the internet was going to be big, right? Like, how would you think at that time? That's how I would think about AI today. Like, okay, I know AI is going to be big. I'm just going to use it as much as I can to solve my problems. I'm just going to do what I need to do in my day and start using it. Once you become like, you're not going to become, no one is an internet expert anymore, just as a heads up. There's like nobody that can Google really well, right? Like, you're not going to prompt really well. That's like a ridiculous concept. Like,
you mean prompt engineers?
Yeah, like the prompt engineering thing is the funniest, most ridiculous thing I've ever heard in my life. Like, it's like saying like, I'm really good at Googling. It's like stupid. But what needs to happen is that people need to start using it in their day-to-day lives. Start using it. It will suck in the beginning probably because you don't know what you're doing. But that's okay. Just like the internet, I remember just like trying to find stuff on the internet and being like, this is so stupid. Like, why can't I get what I want? And now I can literally put in 2 letters and it knows what I want. It even finishes my Googling for me. So, AI, like the internet, is going to develop, and it's going to be so crazy, and you have no idea what it's going to be. So stop trying to predict it. Just ride the wave. That's the way I think about it. And it's just like, start using it to solve your problems today. Stop worrying about the solution it is, and start thinking about your problems and how it solves that.
I think you have to keep on, just that, the question you should be asking isn't what can I do with AI? It's when you talk about a problem, can I is AI part of that solution? Can I incorporate it in, like in Samir's case, can I incorporate it into what I'm doing? Does it make what I'm doing more effective and stronger and more innovative?
And
That-
can AI
that's
help me
important.
come up with the solution, actually,
Yeah,
also?
or you can do that. Yeah, but I do admit we just got about 10 minutes left. I would make sure that if anybody does have additional questions, bring them in the chat. There was one other kind of common comment I wanted to bring up, and that was regards to, there were a few comments that all kind of tied into the idea of what can patients do. And I think what's interesting, because while we're all in this industry, we're also all ultimately at one point in our lives patients, and in many cases have, as the examples were brought up, cared for others who are patients. What can patients do to drive innovation? I think that's an important aspect of it as well that we didn't really talk about.
So that is the premise behind what we're doing. Without being able to say much about what we're doing, we have 3 divisions. We have something called DX, which is the doctor's experience. It's a pun on the abbreviation for diagnosis. We have TX, which is TX. That's the technology that we're going to be using to help the doctors. And then we have PX, which is going to be probably your biggest division. That's the patient experience. We have an entire division just focused on patients, people. And the reason for that is because they are the end users of healthcare. That has to be the most critical component. We don't believe, as a general philosophy, that there exist many healthcare institutions today that ruthlessly and relentlessly pursue patient satisfaction. Very few. And we want to be known as a healthcare company that does that. And that means any feature that we launch, any service that we launch has to be done with a very specific mission. Does this increase the satisfaction for our patient? Does it increase convenience for our patient? Does it increase access for the patient? Does it decrease cost for our patient? We're going to keep doing that over and over and over again. And I'll give just a couple of quick examples of 2 features we've created using AI. One is, why does it take an act of Congress to be able to get your own medications refilled? When you've been on the same medicines for 5 years, you're called in unnecessarily. Why? And there's all sorts of theories about why. Sometimes it is a legitimate need. You got to get your blood pressure checked. You haven't gone in years, fine. But most of the time, we all know this as clinicians, you don't really have to. And so we've created an algorithm where patients can essentially request their own refills using AI, all with the doctors supervising and looking over everything. But the patient can literally request their own refills, and it gets done within an hour. That takes it further. If I or Danish say we're doctors practicing, and if you needed your own refills, I don't know if you've gotten any new medications from another specialist. Maybe you were put on certain supplements. What if they all interact with each other? If I just say, oh, this person's going to file a complaint with the medical board, let me just go ahead and do the refill. It's going to take me 2 seconds. What if that interacts with something that your endocrinologist just put you on 2 weeks ago that I don't even know about because I didn't get those notes yet? Imagine if our algorithm then asks the patient, have you been put on any of new medications? Here's a list. Have you been put on any new medications, any new supplements? And then it uses AI, which is machine learning. You can actually teach it to look for the drug-drug interactions that are harmful to the patient. And if there's any positive match, it reroutes the patient back to us to make an appointment and discuss anything before the refills are blindly filled. So we're doing stuff like that. We also learned during the pandemic that patients like to be the protectors of their own healthcare data, of their own choices. We learned about that from vaccination debates, from mask debates, and so forth. So we live in a society today where a lot of people are literate enough to know what kinds of labs they might need for their conditions. I mean, half of my patients come in with a Google diagnosis already. So if you can't beat them, join them. Help them find the right information. Help them order their own labs. The now infamously defunct Theranos did one thing. It helped the state of Arizona put into law where patients can actually order their own labs. That's not a new thing, by the way. You can go to Quest today and order your own labs. Now, are the patients really ordering their own labs? No. Somebody at Quest is overlooking all of that and making sure that they can sign off on it. But imagine if you had an AI algorithm, which we have, that based on your symptoms, lets you know what are the best labs to order for possible conditions that could be going on for your symptoms. We do that in medical practice. Why can't we teach an AI algorithm to do that? So we're doing that. those are two of our features that we're launching. One is a way for patients to accelerate their own refill process safely. And another is to use symptoms to help you order your own labs with physician supervision. So those are some of the places we're going with AI, and I think it's only the beginning for us.
You know, I think one of the things that comes to mind with all this is, and Dinesh was talking about the internet and now AI. When I think about that, I think, okay, the internet took a while, right? I was using two of those 52K modems to go a little faster, right? And, doing all sorts of things. And it took years, right, for this thing to get to what it is. I think with the current move to ChatGPT and other OpenAI stuff, right? The fact is, it's going to move incredibly faster, because right now you don't even need to teach yourself how to do these things. You don't need the prompts for Google anymore, because you can actually ask the robot, how do I do this? How do I actually get you to give me the answer? What should I be asking you? And it'll actually tell you. I mean, I play with it and it's fascinating to me that I can ask it about any kind of plugin and say, all right, well, now I'd like to do this and I'd like to get to this point. And they go, well, to do that, you need to provide me with this and I can surely help you. And, so it walks you through it, right? The one thing I wonder is, that kind of ability, will that allow us to keep up with it? Or will we end up even faster than our parents did in a situation where they couldn't program a VCR, right? Do we get outrun by this stuff? Or does this kind of self-feeding loop help us stay on top of it? I don't know the answer to that, but I'm watching very interesting. I think it's a very interesting evolution that we're going to see in the next few years.
So we're getting close to the end. I do want to make some kind of wrap up comments and give you guys each a chance to wrap up yourselves as well. We had some interesting talk about AI, and I do want to mention for those of you local to the Las Vegas area that we're going to have in partnership with Las Vegas Heals and ACHE, we're going to have a event on August 9th in person at CSN to talk about generative AI in healthcare specifically. I would encourage everyone to attend. Samir, maybe we should chat about if you're interested in being a part of that as well. So we have other events coming up, but that one obviously ties right into what we were discussing and is one of our next major events. So I would encourage you to check that out and keep an eye out for emails coming out about that. It mentioned also, that this topic in this session, we cover a lot of different ideas, a lot of different things, and this group could talk for many, many hours more, I have no doubt. And I think that you're looking at it, I'd really I think that the biggest takeaway that I would suggest is to kind of think differently as new problems are coming across your desk, to sort of challenge a little bit of the status quo, ask different kinds of questions when you're looking for solutions, to think about different ways you can approach it, maybe the way that some disruptive startups or other companies are approaching it, or others in the healthcare industry that are seen as more leaders and innovators, and just think about it differently, not accept that the status quo is the way that it has to be. And I think if that's the one thing that you take away, I think that's probably what's most valuable and what's important. So I'll give everyone an opportunity to just share some closing thoughts. Samir, you want to go first?
Sure. Well, first of all, thank you for having me here. This is a lot of fun. I think, again, reiterating what I said earlier, disruption is not necessarily the answer. Innovation, I think, is probably a better way to put things. We have a responsibility to improve this planet, improve healthcare, improve society. And it doesn't matter whether you're a physician or a nurse or a healthcare executive, a computer scientist, an entrepreneur. Healthcare touches all of us. We're all human beings. We're all going to become the recipients of some type of healthcare at some point or another. So if you can think of anything that helps the system improve itself in terms of convenience, access, cost, quality, thank you. We need more of you.
Thanks. Let's go next.
I'll go. You know, I think at the end, if we ask ourselves, what can we do to help with innovation and to help push forward, right? And like Samir is saying, improve the planet. I would say on an individual level, every time that we are presented with a particular idea, project, option, whatever the case is, and many times we are in meetings where several people are being asked, what do you think about this or that, right? I would say that we need to ask ourselves, is what I'm going to say now or what I'm saying already going to help change, or is it going to just stop it? Right. And I would liken it to, when folks say, don't think negatively, think positively, right? It's not about what if this happens, is what if it doesn't, right? What if it doesn't and everything works great? So I think having that kind of reminder to ourselves when we are presented with things, that our gut reaction shouldn't just be, I don't know about this, right? It should really be, let's explore it and understand properly the benefits that this could bring. I think that'll help.
Thanks, Cameron.
I think one of the most interesting opportunities over the course of the next 10 years is going to be how does healthcare transform itself? It's a very interesting world we're living in. About, I would say, 10 years ago, very little of care delivery was digital. Very little of the actual delivery of care was digital. And I think that there's something happening right now. The answer may not be exactly right in front of us. Obviously, I believe it's what we're building, but it doesn't mean that's the answer for sure for the whole thing. But there's something happening about where does healthcare go from here? And how do we think about the care delivery stack? And how do we think about our decision making? And how does this all get disrupted? We're sort of where, you remember there was a point where you had Kmart that was still open, but it was getting closed down, and Walmart was coming up. There was this company with Amazon that still represented a very small amount. We're sort of in that moment in healthcare right now. And what I would recommend for the people that are listening is, like Guillermo said, have a growth mindset. Think about what is possible. You've got to do your due diligence, of course. But what I would recommend is sort of think about the world 1 or 2 years from now. It's impossible to know what's going to happen 10 years from now. But start thinking about, okay, there's something happening here. I'm hearing from people that something is changing. Maybe I should keep my ear to the ground. Maybe I should be aware of what's happening. Maybe I shouldn't just close my eyes and do the same thing close my ears and do the same thing I've been doing for the last 5 years. We are at a watershed moment in healthcare. I am convinced of it. I'll end with this last thing. Crisis breeds innovation. The fintech industry, all of crypto, all of that stuff came from the global financial crisis. You can go all the way back to tulip mania. You can go all the way back to the railroad crisis, and you'll keep seeing that the industrial organization came after that, after the railroad crisis. And so there's this thing that happens after these major crises. And if you can sit down and say, what has been the biggest crisis of this decade? It has to be COVID. It has to be the pandemic. It has to be what we all went through. Healthcare will never be the same. There is innovation coming from that crisis. Now, you can be on the train or you can see the train from the sidelines. I think the reason why you're here is because you want to be on it. So don't forget that. Know that there's something coming. And that's enough, honestly. As long as you know something's coming, you're going to be looking for it. And sometimes awareness is all you need.
Thank you. Great comments. All right. So Nan, I need go ahead and pass it over to you to close out the session.
Oh, thanks so much, everyone. Appreciate it. I wanted to make sure you noticed that I had put the evaluation link in the chat for everybody. I'm going to go ahead and do it one more time before you leave. Feel free to just grab that and copy it. But thank you for everyone's time this evening. Thank you to our panelists and our moderator. I do want to mention that this is a copyrighted event in 2023 by the American College of Healthcare Executives. All rights are reserved. I'm going to hit the recording button so it'll stop, but I'll stay on in case you want to go ahead and grab that link. Thank you, everyone.